Hi, this is Andrew Marin. Today we're going to talk about a case of an MCL and PCL reconstruction. So I thought this was an interesting case because most of the time MCL injuries can be treated without surgery, and same with the PCL. The PCL is much less likely to need surgery than an ACL, where we frequently do an ACL reconstruction. But sometimes when multiple ligaments are injured and there's continued instability, we have to do a reconstruction. So this kind of was an interesting case because it presented both of these rarely or less commonly treated surgical cases. So let's just get into it. So first of all, we got our knee model again, and we've seen this previously for the ACL. And so what we're going to look at now is the MCL, which is on the inner side of the knee joint. And instead of looking at the ACL, which is this front ligament, we're actually going to look at the PCL, or the back ligament. So these are generally injured by what we call dashboard type injuries, or a direct blow to the front of the knee. In sports, this can be because you're running in football, someone trips you and you fall down and land onto the turf with a bent knee and pushes the tibia backwards. Now that stresses this PCL. If that gets bad enough, you can also injure the MCL. And that was how this injury had occurred. Pushed back too far, injure the PCL, and then the MCL. So much different than the rotational type injury of an ACL. And so obviously ACL is injured more because we're always rotating when we're playing sports, and rarely are we falling directly down. Now, this has been recently in the news because of a famous NFL athlete that's had this and PCL alone and was treated without surgery, got back to playing in the NFL. But in this case, this patient had continued instability, and so we had to go and do a reconstruction. So let's take a look. So as always, we start by looking at what's normal. So here are two MRIs, normal on the left and injured on the right. Normal, what we want to see is this MCL, not a lot of white. Remember, MRI, if we see white, either it's blood vessels like we see up here, or an injury. So MCL is a very dark ligament running down the inner side of the knee joint. Here what we see is the MCL still okay down here, but as it gets up here, it never healed. We give this time to heal conservatively. It never reattached up at the femur here. So this is the top side. What we're looking at again right here is the MCL, but it's been pulled off and never reattached up at the top here, okay? So that leads to continued instability. If we'll see some x-rays where we test this, and you can see that the inner side of the knee joint opens up. So that's the MCL injury in this case. The PCL, similar to the ACL, we got to look at a different view. We look at the front of the knee here on both sides. Here's the kneecap. So we're looking at the front thigh up towards the top, foot down here to the back, and we're looking at this ligament here. Now it's hard to get the PCL all in one view, so you just have to kind of look at this with me. The PCL, usually a very dark ligament, and what we want to see is continuity from the front on the femur to the back on the tibia. And here what you see is lack of that continuity. You see the PCL come, and then this is all the part that pulled off down here. So a big separation. This never healed. This was a complete tear, never healed. So they have continued instability. So how do we test for that? Well, we actually do what's called a PCL stress x-rays. And we always compare to the other side because everyone's built a little bit differently. So this is the left side's the injured side. So let's start on the uninjured side. And what we're looking at is where the back of the tibia goes and hits the femur. This is a little advanced, but fast forward if you don't want to. This is the stuff that I like talking about. So what we're doing is having them kneel on a bench right here, and it's pushing the tibia backwards, and we're seeing how far back this goes. Here you can see it would do the same thing over on this side, and how much further from the back of the condyles this went versus here, which is pretty much in line. So this side, which has the injury, does not stop because the PCL connects this way. So it stops, sorry, this is getting messy here, but it stops this way at translation of the tibia backwards, the tibia being the shin bone. So you can see how much more this has pushed back versus this side, which is nice and stable. So this is the stress x-rays that we get to quantify how much of this laxity is present. On the MCL, we do the same thing, which is that I'm actually, you can barely see my hands here, I'm actually pulling the tibia open. I'm showing that motion of the PCL, and this opens very broadly here. This is, we also get it on the other side, but this shouldn't be nowhere near 15 millimeters, usually 8 millimeters or so. So the MCL is also not stopping. Remember, the MCL runs up and down this side. It's not stopping me pulling the tibia off to the side. So these are the x-rays that show us this. When we get to the arthroscopy, I have normal on the left. This is a different patient, and you can see the narrowness between this is looking at the inner side of the knee joint. This is the end of the femur, the top of the tibia, and how narrow. We can barely see the meniscus sneaking around the back there. And now, oh my gosh, called a drive-through sign. We can see how big. We can see the complete meniscus and even more. And all of this space is because that MCL cannot prevent us, because the MCL runs up and down over here. And that's just showing us what that does to the joint when we don't have an MCL. We then do the PCL reconstruction. So PCL reconstruction is bringing new ligament, just like if you've watched the ACL videos, we got to bring a new ligament up into the knee. But now we got to reach the back of the knee. So we use this pin to drill, and we want this tunnel to come out the back of the knee, because ultimately this is going to connect, the PCL is going to connect towards the front of the knee. This is where we've centered our drill inside the knee, so onto the femur. And so we're going to drill a tunnel on this side, drill a tunnel up into the femur, and connect new graft tissue across those two. So here's that tunnel into the femur. And then here's now our tissue that we've brought into the knee joint. The PCL is very big, about 12 millimeters in diameter, so bigger than an ACL, going down towards the back of the knee. Now, this person had a normal ACL, so it's actually hard because we got to kind of work around that. But here's now the PCL tissue coming out of the femur, transversing the joint towards the back of the knee. Here's at the end of the case, what you can see still. This, remember, if you watch the ACL videos, the ACL is still intact. It's going from the front of the tibia to the back of the femur. And the PCL does the opposite. It starts in the front of the femur and goes down to the back of the tibia. So this is just the crossing that shows how the PCL and ACL work together. Post-operative x-rays, we can't show the MCL that well because it's not done with an arthroscopy, but essentially what we do is we bring a new ligament up the inner side of the knee joint. There's a little anchor that we have right there, a little screw, and there's new tissue that comes down. We attach it down here as well as here, and then we add some backup fixation to both support the sutures from the MCL, as well as this is that tunnel we drew for the PCL. The PCL tunnel heads towards the back of the knee, as we talked about. It comes out right here and then goes into the joint up in here. So x-rays, of course, they make a lot more sense to me, but just trying to show you sort of what to expect with this type of injury. Now, these are longer surgery recoveries, different than an ACL. So non-weight bearing for 6 weeks afterwards, or even longer, at least 6 weeks if it's just an MCL. If it's an MCL, PCL, we'll add that up to about 3 months depending on the extent of the injury. And bracing is very important because we're protecting the MCL and the LCL from getting too much stress early in the recovery. By 3 months, hopefully we come out of the crutches, off the crutches, out of the brace, but really just doing daily activities, physical therapy, exercise bike, nothing too strenuous on the knee. These take longer to heal, especially the PCL. So by 6 months, we're still doing daily activities, no sport-specific drills or anything. Really 12 months till sports for these type of injuries. Again, depending on the situation, we play it even a little bit longer. These grafts we know take longer to incorporate, 24 months or so. So we try to balance getting people back doing their activities early, but then not risking a re-injury. Typically, surgery for this takes about 2 hours to do a PCL, maybe a little bit longer if we have to do meniscus, anything else. It is an outpatient surgery. You go home the same day. And this is sort of an overview of an MCL and PCL reconstruction. Again, Usually these aren't needed unless there's a combination injury, but when needed, it's a good surgery to give stability back to the knee joint. As always, call or let me know if you're dealing with this, and we'd be happy to talk you through it. Thanks for watching. Talk to you soon.